thank you for taking the time to join us. This is going to be a first webinar and potentially a series of webinars all around different aspects of cancer therapy. My name is John Syme. Matthew and I are two of the co-founders of Primum, and we're going to get started today with our topic. And we have two great oncologists here, Drs. Trivedi and Narkhede, who will lead the discussion. But I'll just give a brief intro to what we're going to cover off on here. So today's topic is focused on navigating frontline therapy and bispecifics in DLBCL. Here is just a brief disclaimer around the information that we present during the discussion today. And then the agenda for the discussion, we're going to start with a brief introduction to both of the speakers, and then we'll dive into a case around frontline DLBCL therapy, move into a discussion of bispecific therapy utilization, talking through the lens of a specific patient case, and then we'll hopefully leave some time at the end for Q&A. The bulk of our discussion will focus on that frontline DLBCL therapy, and then we'll move on to bispecifics. Any time left over will be focused on Q&A. So if you have questions, feel free to drop them in the Q&A box during the discussion, and then myself or Matthew will interject with those. But to get us started, let's go with some introductions. So I'm going to pass the microphone over to Dr. Narkhede to just give a brief intro to himself.
Good afternoon, good evening. My name is Mayur Narkhede. I'm an assistant professor at UAB. I specialize in CLL and all things lymphoma. I've been doing this for close to 5 years now. I'm happy to be here talking about DLBCL today.
I'm happy to be here too, Dr. Narkhede. Thanks for having us, John. My name is Neel Trivedi. I'm a hematologist oncologist out at Nazareth Hospital in Northeast Philly. I'm about 4 years out from training. At my past job, I used to be kind of a specialist in GI malignancies, and now I do everything since I'm the only practitioner at my hospital. Next slide, please. These are disclosures. You can read them there. Next slide, please. So a quick summary about the app. So Primum is a quick way to do kind of online curbside consults with disease experts. The app covers a lot of different disease areas. They have over 60 disease specialists in solid tumors, lymphomas, leukemias, and even benign heme. And they have a lot of active users right now. Experts usually respond, in my experience, within 24 to 48 hours, but usually it's a lot quicker than that. So it's a very quick way to really get some expert advice on complicated patients if you have a specific question. Today, we wanted to do some kind of live cases, real-time cases, based on cases that were sent into the app. So we'll start off with frontline DLBCL. So this is a 69-year-old patient, ECOG1. They have a history of hypertension, hyperlipidemia, and sought medical care after developing some bulky inguinal lymphadenopathy. They had a PET scan that showed some FDG avid lesions above and below the diaphragm, as well as some osseous lesions on the PET scan. Their LDH was significantly elevated, and an excisional biopsy was done of one of the inguinal lymph nodes that showed DLBCL GCB subtype. Further FISH testing was done, which showed BCL2 rearrangement, gain of BCL6, and gain of MYC, as well as a MYC amplification. Next slide, please. So we can start here, Dr. Narkhede. I feel like we were very smart in picking out who are the high-risk patients and those kinds of things, but not as smart as figuring out what to do for those patients. So could you tell me kind of briefly about how you define a high-risk patient and diffuse large B-cell lymphoma, and kind of how that subgroup influences your decision on frontline therapy?
Sure. So the subgroup definition in DLBCL is a constantly moving target. Every few years, we come up with a few new criteria. But I think the three main groups that you should be aware about as a practicing oncologist. First is double hit or triple hit. These are FISH studies that show MYC rearrangement in addition to BCL2 or BCL6. It has to be a rearrangement. For example, in this example, we only have BCL2 rearrangement without the MYC. So this is not a double hit or triple hit. The others are double expressor lymphomas. This is on immunohistochemistry. So when we stain for MYC and BCL2, if they're present and more than 50%, we call them double expressor lymphomas. Now, in terms of other criteria or subgroups, there's a non-germinal subtype of DLBCL, which is based on cell of origin classification. We normally don't use gene expression profiling. We use Hahn's algorithm. So that's an algorithm or something that your pathologist will put down as non-germinal subtype of DLBCL. Now, in case of what treatments we use, in terms of these high-risk subgroups, only for double hit or triple hit, we decide to use our EPOC. But for others, you are safe to use our CHOP. And we can get into the details of other regimens between R-CHOP and R-CHOP-POLA as we go through some of the slides.
Sounds good. Next slide, please. I think this is a common question that I always have. And I feel like there's a big difference between the community and the academic world, where I think more procedures tend to be done in academics. Maybe you guys want to get your fellows some practice or something like that. But this is always a question that I have, and NCCN guidelines are never 100% clear. So when do you like to do bone marrow biopsies in the management of lymphoma patients? And specifically for this patient, would you do one?
Not for this patient. I mean, if we have an enthusiastic fellow, sure. I mean, if they want to, but for the patient's sake, these are painful procedures. So with the PET scan era, I don't do a bone marrow biopsy. This patient clearly has osseous lesions. The bone marrow biopsy is not going to give us additional information. We used to do it in the past if there was a significant difference in staging. So presence of bone marrow would make it stage 4, but if you already know it's stage 3 or stage 4, doesn't make a lot of sense. You can do it in elderly patients. Sometimes I do have patients with disproportionate cytopenia. So maybe a one side of disease, but they have neutropenia, severe anemia, which doesn't fit with the picture. So you may want to do a bone marrow biopsy, make sure they don't have MDS. But outside of that niche situation, we don't do bone marrow biopsies at all with PET scans available.
Okay. Can I ask you a hypothetical question? So
Sure.
say you have a young patient, just lymphadenopathy above the diaphragm, DLBCL. So they're going to be a lower stage lymphoma. In those patients, if they didn't have cytopenias, would you still put them through a bone marrow biopsy just to try to upstage them?
No. A younger patient with normal counts, I would not do it.
Okay, that's helpful. All right, next slide, please. So this is the crux of the matter. What would you recommend for this patient? Since nowadays we actually have more than one option.
Yeah, so there are 3 standard regimens which we can use. I mean, I mentioned our dose suggested our EPOC, which is for double hit, triple hit, primum, mediastinal, and HIV, which this patient doesn't have. So we're left with 2 other options. We either have R-CHOP at standard doses, because this is a 69-year-old guy with a good performance status, or R-CHP-POLA, which is the vincristine swapped with polatuzumab. Now, it's approved for patients with an IPI score of 2 and above. This patient would technically qualify as IPI 2 at the least with the age and stage. So he would meet the label indication for R-CHP-POLA. But because the difference in PFS is so small, I tend to only use R-CHP-POLA if you have a non-GCB subtype. This patient has a GCB subtype. Or if they have an IPI score of 3 and above. If this patient does have a higher LDH, so this IPI score will be 3 at least. So this patient would be a perfect patient for R-CHP-POLA. But if he didn't have an elevated LDH, it's just regular R-CHOP is sufficient, and they do well with that.
Okay. I have another question for you. So you mentioned the PFS data. We don't have OS data on this yet. What do you think is going to be the result once all that data is mature?
I don't think we're going to see an overall survival benefit because at the cutoffs, at 2 years, we have a 7% difference in PFS. And
Mhm.
our past experience has shown that if you don't relapse within 2 years, it's unlike your survival is similar to age-matched controls. So if the overall survival is very similar at that time point, we shouldn't see a separation of curves further down the road.
Gotcha. All right. Next slide, please. This is another question that I think I commonly have, and I feel like a lot of other people do. When do we need to do, or when should we do interim PET scans or other imaging? Do you have kind of a standard practice that you do for everybody, or is it more case-based?
So PET scan is I tend to do it for everybody. It can be done either prior to cycle 3 or prior to cycle 4. I say prior because you actually need 1 or 2 weeks after you give an R-CHOP treatment or R-CHOP. There's more prognostic value if you do it prior to cycle 4. And this is based on a consortium study. What we're looking for in this PET scan, we occasionally see complete response, but if we see reduction in the lymph node size and or SUV max reducing by at least 70% from baseline, in that case, you know that they're doing well and you proceed. If not, I start the insurance process for CAR T. I would still proceed with the next dose of our CHOP, not proceed with CAR T right away, wait for an end of treatment scan. But given that CAR T cell processing requires some time, I start the insurance approval and other things in this setting. I also talk to my community colleagues to consider referring to a CAR T cell center if they feel that the interim PET scan doesn't look as promising as we thought it would look.
That's fair. So it really doesn't change your management for at that time, but kind of helps you lay the road ahead, because it sounds like CAR T is quite the insurance hill to jump over. Okay.
The other situation sometimes it's helpful is if you have a patient not tolerating treatment well, you could stop it early on.
Mm-hmm. Gotcha. That's really helpful. Next slide, please. So as an expert in this field, you kind of get to see the long-term side effects and those kinds of things. What, in your experience, tends to be the most common side effect that people are dealing with after treatment? And have you learned any tips and tricks to help us kind of manage those?
Yeah, I mean, so basic things. Everybody above 65 gets a growth factor support. If you have somebody with questionable performance status, you can start with our mini CHOP, so half the doses, close to half. You can escalate with subsequent cycles. I try to cap the vincristine early on if they tell me that the neuropathy is pretty troublesome, even before the pain starts. I cap the vincristine. If you're using POLA, I would dose reduce the POLA as well. If they get febrile neutropenia despite growth factor support, then I reduce the cyclophosphamide as my first dose reduction to 600 from 750. Those are the common things. People with higher cardiac risks, I only do an echo before. I don't repeat it again. Because the reason for this is we always see a drop in ejection fraction if we tend to do it after 3 cycles. The problem then arises is what do we do with this information? Because they're not clinically uncompensated. So it's better not to check unless they're symptomatic and not do an echo unless they're symptomatic.
That's really helpful. Have you noticed a difference in the neuropathy between people who got R-CHOP and then the R-CHOP-POLA? Or is it pretty similar?
I mean, they're pretty similar. Clinical trial data is pretty strong in terms of how similar they are because it was a placebo-controlled blinded study, and they're exactly the same. You can't get any better data than that.
That's great. So it sounds like comorbidities don't especially sway you from one regimen or the other in a kind of borderline case.
The only condition it will sway me is a low ejection fraction. In that case, we may have to switch the doxorubicin with gemcitabine.
Okay. Fair enough. Next slide, please. So this is another good question. So what is your typical kind of surveillance plan or post-treatment regimen, and then what do you do afterwards?
Yeah, so nobody with DLBCL gets maintenance rituximab. I think that should be pretty clear by now. I tend to follow them every 3 months for the first 2 years. at 2 years time point is usually when I take their port out, if we placed in a port in the beginning. If I haven't placed a port, there's no need for that. 2 years time point is a crucial time point. It's because if you don't relapse by this time, your survival is similar to an age-matched control, which I alluded to before. So I tend to use the word you're not likely to relapse at this point, but you can never be sure. And my patients tend to like that because then they can go back to their routine lives. And even if they do relapse, they usually have a better prognosis than the early relapsers.
And when are you kind of completely out of the woods? Is there a cutoff?
Never. I mean,
Never.
5 years, yes. If you get a DLBCL after that, it's probably a second event and not related to the first. So it's a second de novo. It's just bad luck.
Sure. Yeah, but one of my mentors, I would always say, you can throw a small party at 2 years and a big one at 5. That was more for colon cancer than this.
The same thing applies. So same thing applies. Yeah.
Fair enough. All right. Next slide, please. All right. So we'll switch topics to bispecific therapies. I think these tend to be more used at the big academic centers for a lot of reasons that we'll go over. So I think it's a good topic to talk about. We can go to the next slide. Yeah,
Dr. Trivedi, before we head there, we have a few questions in the Q&A coming in around monitoring with an echo. Dr. Narkhede, it sounds like you only use an echo if a patient is symptomatic. Is that true? And would love to just firmly answer that question for the people asking.
Yes, I only use it if they're symptomatic. While they're on treatment. Before treatment, everybody gets it. I do not repeat an echo post-treatment unless they're symptomatic.
I see. Perfect. Great.
I see another question in there. No, I do not repeat echo every 3 months up to a year after completion. That would be a little bit excessive, I feel, unless you have a patient with a low ejection fraction, where you really want to monitor the improvement. In that situation, you would work closely with your cardiologist.
Perfect. Thank you, Dr. Narkhede. I think that covered off all the questions in the Q&A there. I think we can now move over to that bispecific therapy case.
Perfect. So this is a 78-year-old male, history of diabetes. They were diagnosed with DLBCL, non-GCB subtype back in 2021. The patient received R-CHP POLA for 6 cycles and had a complete response, but unfortunately 7 months later developed some enlarging left cervical lymph nodes, and the biopsy showed recurrence of disease. PET scan was done, which showed some FDG, avid cervical, axillary, and inguinal nodes. They didn't have a caregiver, so they weren't really a good candidate for CAR T-cell therapy, and they were started on treatment with tafasitamab and lenalidomide. After 3 months of treatment, his left cervical lymph node increased in size and now has refractory disease. Next slide, please. So to start this off, Dr. Narkhede, it seems like there's quite a few bispecifics out there nowadays. How do you go about choosing which one's right for the patient?
Yeah, so there are two main approved for DLBCL. One is epcoritamab and the other is glofitamab. Choosing between them extremely hard. Efficacy and safety, they're exactly the same. So it comes down to the schedule. Epcoritamab is weekly for 3 months, and then it's every 2 weeks for the next 4 months. So it's much more frequent. Also, epcoritamab requires 16 milligrams dexamethasone for 3 days after each dose. So if you calculate it, they get about 160 to 200 milligrams of dexamethasone in a month. So if you have a patient with diabetes, you can't really give them epcoritamab because of the dexamethasone dose. The glofitamab, on the other end, it's much easier, but the problem is the first dose is Gazyva. And if you have a patient who's allergic or has issues with Gazyva, this is going to be hard. This is not like your regular Gazyva or obinutuzumab where you split it in 2 days. So the entire bulk is given on one single day, 1,000 milligrams. So more people have infusion reactions with the 1,000 milligrams. So that's a little challenging with the glofi. Yeah, in terms of choosing between these two in my practice, if I have a patient that I need to follow more frequently and they don't mind the steroids, I choose the epcoritamab. If somebody wants to be done with treatment sooner, so glofitamab is time limited, so we stop after 12 cycles, I choose the glofi. But you wouldn't be faulted for choosing one over the other. There's no difference in terms of safety and efficacy.
Sure. All right. Next slide, please. So like what we were saying before, it seems like the big academic centers are really the ones that are using this quite a bit. What would a smaller center or private practice need to really administer these drugs safely?
Yeah, I think this question is kind of very interesting when we try to figure out what's needed. So both the drugs have a 24-hour hospital monitoring requirement. Glofi has about on cycle 1 day 8, EPCO is on cycle 1 day 15. If you have an infusion center that's attached to a hospital, that's great. If you work in a private practice that's only an infusion center, but the hospital is across the street or they have to drive, driving is not safe. So that's a big challenge. You need to have an infusion center next to the hospital. Second is after you give this infusion, if the patient has to come back or if they get an cytokine release syndrome, you need to have tocilizumab available. This is not a medicine that every hospital or pharmacy has. So it's going to be pretty challenging to have a lot of cancer centers to be able to give this because of this very reason.
So that first dose, are you giving that in the hospital or in your infusion center as an outpatient?
So the first dose of, it's different for different drugs. So Glofi first dose is 24 hours. So I give them in the infusion, then they go to the hospital, just monitoring. So they all get it in the infusion center, not at the hospital.
Gotcha. Then they go in for monitoring for 24 hours. Great. Okay. Next slide, please. Important question for me. So I know that at my practice where it's just me and we really don't have the ability to handle these complex patients, what in your opinion would be the role of the community physician in these complicated patients?
I mean, I think my biggest advice would be you will have to get used to this. This is coming soon to every cancer near you. So ovarian cancer, endocrine, other cancers, we're seeing this. This may move into frontline setting as well. Having said that, the way we have it situated with our community colleagues is we start up the ramp up or step up dosing. And once they're out of the window for CRS, for subsequent treatments, they can pick up the infusions. For example, if epcoritamab is indefinite, glofitamab is 12 cycles. After the first cycle, they can pick up the remaining doses. What they need to know is, even though this is immunotherapy, there is a pretty high cytopenia risks. Neutropenia rates are up to 30 to 40%. These are grade 4. And they can have infections, pretty severe infections. So even though this is immunotherapy, think of it like chemotherapy in terms of infection risk. That's mainly it. Infections are the biggest risk with what these therapies are. Other than that, we don't see any other immunotherapy related side effects.
Okay. So after that first dose, it sounds like it's kind of smooth sailing from the CRS standpoint.
Yes.
Okay. What kind of anti-infectives you usually have these people on?
We don't put prophylactically people on anti-infectives because if they get cytopenic, you can, but not everybody.
Sure. Okay, so not everybody gets cytopenic, but it can definitely happen. Gotcha. All right. Next slide, please. All right, John, I think we have some questions in the chat.
Yes, we do. So the remaining time, about 5 minutes. If anybody has any questions, feel free to drop them into that Q&A bucket. First question that we have in the chat here is around if a patient is getting Pola-R-CHP, do you do the 2 cycles of rituximab maintenance after or skip it like we do with our CHOP?
This is an excellent question. I will tell you that we do not do the maintenance rituximab after the R-CHP Pola. This question is excellent because this is how the clinical study was done, where everybody got 2 cycles of rituximab after the first 6 cycles. This is because the Europeans like to use rituximab 2 cycles after completing, which is not the practice in the US. So to make sure it's standardized across the countries, because this was a international trial, they incorporated this. We don't need it because bulk of the heavy lifting for treatment of DLBCL is done in the first 2 or 3 cycles. We occasionally see people who get scans for one reason or the other, even with just 1 cycle of R-CHOP or even R-CHOP, they go into CR. So the maintenance rituximab has 0 implications in terms of PFS or OS.
Great. Thank you for providing that response. If anyone in the chat has any other questions, feel free to drop them in there. Otherwise, Dr. Narkhede, Dr. Trivedi, anything you'd like to add to our discussion here?
I just want to say one more thing. In terms of cancer center requirements, it's not just the oncologist, it's the hospital emergency room also need to be educated about cytokine release syndrome because they need to have TOSI available. The catchment areas, so if, for example, Neel practices in Philly, if his catchment area doesn't have TOSI, the ER doesn't carry it, they don't know what CRS is, then your patient's going to be at a disservice because they will treat it like sepsis. And TOSI works amazingly well. The time to resolution is about a couple of hours with the fevers and other symptoms. So there's a lot more education, not just the oncology practice, but everybody else involved, including emergency room physicians, ICU doctors. And this will eventually come, but we're not there yet.
Yeah, it definitely takes time, I think, for the rest of the team to really learn the side effects from some of our medications. I feel like even the immunotherapy has taken a long time for the rest of the medical team to recognize side effects from that and learn how to treat them. So I think it'd be challenging in some of these smaller hospitals to give these drugs.
I see a question out there about methotrexate. So intrathecal methotrexate not routinely recommended or used. It doesn't have the same penetration into the parenchyma, so I don't routinely use it. I think most of the academic centers have stopped using intrathecal, unless it's a rare situation where we have only leptomeningeal disease in the spine, but nowhere else. In terms of IV methotrexate, yes, we use it. There have been collaborative efforts across the countries to find the best dose, timing, frequency, and it's all over the place. I would not intercalate it. That's how we used to do before. We've learned that giving methotrexate between R-CHOP delays the R-CHOP. For many people, about 1/4 to 1/3 people have delayed R-CHOP. We don't want to delay R-CHOP. This is a curative cancer which can be cured by giving dose intensities on time. So we don't want to delay the R-CHOP. So intercalation, we're done with that. So we are left with either giving it with the CHOP or giving it at the end of treatment. Now, if you have a fit younger person, sure, you can give it with R-CHOP. This is more difficult for some private practice setting because there's a lot of coordination required to give methotrexate with the R-CHOP. You cannot give rituximab with bicarb drips, for example, a few other limitations. So in that situation, you can leave it at the end. So you complete the R-CHOP, and then at the end, do 2 or 4 cycles of methotrexate. And that's the same for R-EPOP as well.
Great. Well, thank you for answering that question. That brings us right up to the close of our discussion here. I want to thank Drs. Narkhede and Trivedi for joining us again. If you have any questions for Dr. Narkhede after this, feel free to go to app.primum.co. Check us out there. You can talk to Dr. Narkhede further about other questions. And it's also available in iOS and the Google Play Store. So available on many of your mobile devices. But thank you, doctors, for taking the time with us, and hope everybody has a great evening.
Thanks, John.
Thanks, John. Bye.
Thanks, everyone.